Uh, Good evening, everyone. We just finished the postgraduate and the beginner session. We had the free papers, almost 22 sessions in the morning, and then we start with the actual program of COSCON for practitioners. The one thing that ophthalmologists dread is a systemic complication, be it even poking a needle inside a vein. I think we would have did it more than 20, 25 years back. And when a patient collapses in the OPD, be it because of vasovagal or some other serious concern, we are taken aback for a minute. Here we have a team of experienced anesthetists. This entire program has been conceptualized by Dr. Suman and Dr. Suman, Dr. PM Chandrasekhar, Dr. Iris Rajiva, Dr. Parimala, Dr. Jyoti, Dr. Vinita, and Dr. Jayachandran will be teaching us about the common systemic problems that we face when we are encountering eye patients in the OPD. Over to Dr. Suman. She doesn't need any introduction. For those of us in the eye hospital side, she's very active on the NABH circuit, and she was my ex-boss when I started my career. My first practice, she was the anesthetist for the first surgery I did in private practice. Over to you, madam.
Very good evening. Hari Om, like the scriptures say, Prajwalito Jnanamaya Pradipaha. May the light of knowledge enlighten all of us. Well, when Dr. Elan invited me and said, which topic? I said, why not something which is of significance to all of us, like systemic complications in an ophthalmic practice. Basically, this would enlighten us as how to have a high suspicion index and recognize pre-arrest scenarios before we get into a code blue situation. And of course, how to manage a code blue. It gives me a great privilege and honor to welcome our chairperson, Dr. PM Chandrasekhara, who is a consultant cardiac anesthetist with 50 years of experience, golden years, great veteran amidst us, and a doyen in the field of anesthesia. He is with the Retina Institute of Karnataka. And the co-chairperson is Dr. Jayachandran himself, a senior consultant from Shankar Netralaya, Chennai. He is the chief architect of the Association of Indian Ophthalmic Anesthesiologists. And he's also the present president of the World Congress of Ophthalmic Anesthesia. Once again, welcome both the chair and the co-chair. Now, our first speaker for today is Dr. Anup. He is having 15 years of experience in the field of anesthesiology. Presently, he's a senior consultant at Netradama Super Speciality Eye Hospital. So the first talk by him would be on life-threatening arrhythmias. Let's listen to him.
Good evening, everyone. A warm greeting from Netradama Super Speciality Eye Hospital, Bangalore. At the outset, I would like to thank the organizers of COSCON 2021 for giving me this opportunity. My topic is life-threatening arrhythmias, and abnormality of cardiac rhythm is called as a cardiac arrhythmia. An arrhythmia can present as sudden death, syncope, heart failure, dizziness, palpitation, or can present without any symptoms also. In an ophthalmological setup, where we can get an abnormal rhythm is while getting an evaluated for surgery, we can come to know, or during surgery when the patient is connected to monitors, or during a code blue call whenever the patient collapses, you can present with the abnormal rhythm. Classification of arrhythmia is based on the heart rate, basically. So heart rate less than 60 beats per minute is called as bradycardia. It can be sinus bradycardia or a heart block. Arrhythmia when heart rate more than 100 beats per minute is termed as tachycardia, and which can further classified depending on the QRS duration into narrow complex or a broad complex. Narrow complex tachycardia can be sinus tachycardia or a supraventricular tachycardia, which are regular rhythms, and atrial fibrillation or atrial flutter, which are irregular rhythms. Broad complex tachycardia can be ventricular tachycardia, ventricular fibrillation. Bradycardia is defined as a pulse rate less than 60 beats per minute. Bradycardia can present itself in several different cardiac rhythms, which include sinus bradycardia and varying degree of atrioventricular heart blocks. This is a graph of sinus bradycardia. This is a third-degree AV block. The bradycardia algorithm always assess the appropriateness of clinical condition whenever the heart rate is less than 50 beats per minute, and continue to identify and treat the underlying cause. At the same time, maintain a patent airway, assist breathing as and when necessary, give oxygen, and monitor for blood pressure and oximetry, obtain an IV access, and if available, get an early ECG. At the same time, continue to assess if there are any hypoperfusion symptoms like hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure. No such symptoms, continue to monitor and observe. If any such symptoms, you can give atropine IV dose. First dose atropine 1 milligram IV given. After that, repeat every 3 to 5 minutes up to a maximum of 3 milligrams. If atropine is ineffective in sustaining an increased heart rate, you can try transcutaneous spacing if the facility is there, or go on to give infusion dopamine at 5 to 20 micrograms per kg per minute, or epinephrine at 2 to 10 micrograms per minute. At the same time, consider shifting into a high center where transvenous spacing is available. In an ophthalmic setup, talking about bradycardia, you have to always mention the ocular cardiac reflex. It's also termed as a trigeminal reflex and is defined by decreasing the heart rate by greater than 20% following low pressure or traction of the extraocular muscles. This reflex has most notably been noted in the squint surgeries or also in the facial trauma and regional nerve blocks. This is the ocular cardiac reflex pathway. The stimulation of the trigeminal nerve leads to activation of a motor nucleus of vagus nerve, leading on to suppression of sinoatrial node causing bradycardia. The incidence is 14 to 90% and it decreases with increasing age. Therefore, pediatric population are at most risk of having this ocular cardiac reflex. Triggering factors can be any stimulus, direct pressure, or nerve traction, muscle traction, ocular manipulation, ocular pain, increased pressures, blogs, hematomas, and trauma. The complication, a varying number of cardiac rhythms can happen, sinus bradycardia to cardiac arrest, and other symptoms due to activation of the vagal nerve. Prevention and treatment, only definitive treatment is immediate cessation of the triggering stimulus. Since it is a fatigable reflex, repeated stimulus will flatten the reflex. The other pharmacological management can be tried, which are intravenous anticholinergics such as atropine or glycopyrrolate, and the other thing is blunting the afferent limb of the reflex by giving a block, either retro or peribulbar block. Remember that retro and peribulbar block in itself can cause ocular cardiac reflex. Tachycardia, heart rate in adults that is greater than 100 beats per minute. Tachycardia can be due to fever, shock, medication, stress, metabolic dysfunction, and hypoxemia. Whenever a heart beats too fast, that is more than 150 beats per minute, the ventricles are not able to completely get filled with the blood, leading to decreasing cardiac output and poor perfusion and causing hemodynamic instability. This is an adult tachycardia with a pulse algorithm. Whenever the heart rate is more than 150 beats per minute, assess the appropriate of the clinical condition for this heart rate. Go on and identify and treat underlying causes. Maintain a patent airway, assess breathing and support breathing as and when necessary. Oxygen, if the saturation is less than 94%, supplement with oxygen, monitor the blood pressure and pulse oximeter readings. Always assess for the signs of hypoperfusion such as hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure. If any of such symptoms are there, go for a synchronized cardioversion, or you can consider adenosine also. If there are no such symptoms, assess whether the QRS is wide or narrow. If there is a wide QRS complex and it is monomorphic ventricular tachycardia, then you can ventricular tachycardia, you can give anti-arrhythmic infusions. If there is no wide QRS complex, then you can try vagal maneuvers if it is a regular rhythm. Then you can try adenosine or beta blockers and go for an expert opinion. Synchronous cardioversion, the different doses that are recommended for different types of arrhythmia: narrow, regular, supraventricular tachycardia is 50 to 100. Narrow irregular will be atrial fibrillation or atrial flutter, which is 122 to 100 joules biphasic or 200 joules monophasic. Wide regular will be 100 joules, and wide irregular will be ventricular fibrillation. So you have to give a defibrillation without synchronization. Adenosine can be given in the first dose 6 milligrams rapid IV push followed by a normal saline flush. If the rhythm is not reverted, then you can go for a second dose with 12 milligrams rapid IV flush. So anti-arrhythmic infusion for stable white QRS complex that can be given are procainamide, amiodarone, or sotalol. Coming to a cardiac rhythms without pulse, whenever you see the person who has arrested without a pulse, immediately start high quality CPR. There can be two types of rhythm which can be found in these patients, a shockable or a non-shockable rhythm. The two shockable rhythms are ventricular fibrillation and ventricular tachycardia. Ventricular fibrillation, common cause of out of hospital or unwitnessed cardiac arrest, presents as a wavy disorganized line as shown in this picture. Another rhythm, shockable rhythm, is pulseless ventricular tachycardia, presents as a wide, regular and very rapid rhythm without any pulse. Treatment is defibrillation with 200 joules biphasic or 360 joules monophasic. Continue with the high quality CPR after shock. And you can give intravenous epinephrine 1 milligram every 3 to 5 minutes, or can consider amiodarone 300 milligrams followed by a repeat dose of 150 milligrams, or lignocaine 1 to 1.5 milligram per kg. Asystole is a non-shockable rhythm, sometimes referred as a flat line on the monitor. Whenever you see a flat line on the monitor, always double check the leads are connected properly. Then you will go on to make a diagnosis of asystole. The other non-shockable rhythm is pulseless electrical activity. It can be any activity on the ECG monitor without any palpable pulse except fibrillation or asystole. So in an non-shockable asystole or pulseless electrical activity, you will continue with the high quality CPR. We can give epinephrine IV every 3 to 5 minutes, 1 milligram, and continue to check the rhythm every 2 minutes. You should always look into reversible causes of the arrest, like the 5H and 5Ts, and try to correct them. Panic attack requires a special mention in this condition because it can pose a difficulty in diagnosing the arrhythmias and its causes. So panic attack presents a palpitation, sweating, trembling, lack of air, chest pain, and all. So normally whenever you evaluate a person with a panic attack, there will be some sort of attack in the past and some sort of phobia associated with it. And there can be some medical condition which can trigger a panic attack, the thyroid, asthma, heart problem, neurologic symptom, or substance abuse. Medication that can abate a panic attack, acute panic attacks, anti-anxiety drugs, especially the benzodiazepines, IV, can be given. Beta blockers and antidepressants are for long-term use. There can be non-pharmacological therapy like psychotherapy can be used for panic attacks. Conclusion: an arrhythmia can present in any form at any point of time. The primary aim, although, is correcting the rhythm. A detailed background checkup into the cause and treating them goes a long way in preventing further attack. Thank you.
Thank you, Dr. Anup, for a well said talk on, especially on panic attack, which is we see it very often and very well covered. Our next speaker is Dr. Vinita SK, a very young, dynamic anesthesiologist from the Institute of Diabetes and Eye Care, which is a unit of Shraddha Eye Care Trust, a charitable initiative of Netradama. Over to Dr. Vinita. Her topic is hypoglycemia and management of diabetes mellitus.
Good evening. My talk today is on diabetic emergency. I will be talking mainly about hypoglycemia and its management. At the outset, I would like to thank Karnataka Ophthalmic Society for giving me an opportunity to deliver this talk. Hypoglycemia, as we know, occurs due to a relative excess of insulin in blood in comparison to blood glucose. The level of blood glucose at which symptoms occur can vary from patient to patient, and it can range from just being a mild lowering of blood glucose with minimal symptoms, which usually occurs at a capillary blood glucose level of 70, to more severe hypoglycemia, which occurs at less than 40 milligrams per deciliter, and this usually presents with neurological symptoms. It's important to know that the hypoglycemia is not diagnosed based on an absolute blood glucose level. Instead, it requires the fulfillment of a Whipple's triad. There should be signs and symptoms consistent with hypoglycemia, There should be associated documented low blood glucose level, and there should be relief of symptoms on administration of supplemental glucose. The signs and symptoms of hypoglycemia mainly occur due to two reasons. The adrenergic symptoms occur as a result of excessive sympathetic stimulation in response to falling blood glucose level. This can present with anxiety, pallor, excessive sweating, or tachycardia. And the neuroglycopenic symptoms, usually occurring due to the low central nervous system levels of glucose, present mainly with neurological symptoms in the form of altered mental state, impaired concentration, confusion, disorientation, or slurred speech. If untreated, it progresses to more serious symptoms like focal seizures and chorioathetosis. The rate at which the adrenergic symptoms are manifested depends upon the rate of fall of blood glucose levels. That is, more acute onset of hypoglycemia tends to produce more pronounced adrenergic symptoms. Adrenergic symptoms tend to precede the neuroglycopenic symptoms as an initial warning system to the patient about impending more serious hypoglycemia. If hypoglycemia has not been treated adequately at this stage, then the medullary phase can set in, where very low blood glucose levels of less than 10 milligrams per deciliter can exist, and patient can present with deep coma. At this stage, if treatment does not occur, patients tend to have more permanent neurological deficits and impairment. Risk factors for hypoglycemia are many. As we know, type 1 diabetic patients have an absolute lack of insulin, which puts them at a risk for diabetic ketoacidosis. However, they are also at risk of hypoglycemia because they tend to have impaired counter-regulatory mechanisms. Islet cell secretion of insulin is a potent stimulus for counter-regulatory hormone like glucagon to be secreted. Hence, impairment of islet cell secretion can impair the counter-regulatory hormone that is glucagon function as well. In the inpatient setting, the most common cause of hypoglycemia is a mismatch between the caloric intake and the timing and administration of insulin. Several other risk factors like chronic kidney disease, chronic liver disease, excessive alcohol intake, or malnourishment can all deplete the glycogen stores in the patient, and the first line of defense against hypoglycemia can be impaired. So these are all a risk factor for hypoglycemia. Any intake of drug in the clinical setting, that is adrenergic blockers, which will mask the initial symptoms of hypoglycemia, and intake of oral hypoglycemic agents like long-acting sulfonylureas can all predispose the patient to hypoglycemic events in the perioperative period. However, the most common cause of hypoglycemia in the perioperative period is a prolonged NPO status in anticipation of surgery, especially when it is in an unplanned setting. How do we avoid hypoglycemia in the perioperative period? All patients, especially diabetics, needs to have a thorough preoperative evaluation, irrespective of what kind of anesthetic they're coming for, because they need to be given a correct and a clear advice on how to manage their insulin and anti-diabetic agents in the perioperative period. At this point, it's also important to ask for the history of any hypoglycemic events in the past, how recurrent it has been, and how serious it has been. All the diabetic patients need to be posted as the first case of the list, and once they are admitted and once the NPO status is initiated, it's important to check very capillary blood glucose levels every 4 hours, both intraoperatively and postoperatively, up until the time patient can resume the regular food intake. Treatment of hypoglycemia is, as with any other medical emergency, we approach it by the airway, breathing, and circulation approach. Once it is established that the patient is responsive and hemodynamically stable, we can take history from the patient regarding when the last dose of insulin was, the timing and the amount of last food intake, and we can also quickly do an assessment for presence of any IV access. A capillary blood glucose level at the bedside has to be checked in order to document the severity of hypoglycemia. This is an algorithm showing the treatment of hypoglycemia in clinical setting. If there is clinically symptomatic hypoglycemia with documented capillary blood glucose level equal to or less than 70, the first question we need to ask is the patient responsive? If the patient is not responsive, then an immediate IV treatment of hypoglycemia with 25 grams of glucose, that is 50 ml of 50% dextrose, is to be initiated. If the patient is responsive and if the patient needs to be NPO for any reason, then again, an IV treatment of hypoglycemia is to be established with 50% of dextrose. In both the settings, if an IV access is not available, then glucagon 1 mg IM is the way to go in order to immediately and promptly treat hypoglycemia. However, if the person is not unconscious and if the person does not require to be NPO, then oral treatment of hypoglycemia can be considered with 15 to 20 grams of oral carbohydrates. By this, I mean giving the patient around 4 ounces or 125 ml of non-carbonated or non-fizzy sweetened drinks like an apple juice or an orange juice. Or if the person is able to take a meal immediately, it has to be ensured that this is done. And irrespective of whether the oral or IV treatment of hypoglycemia was initiated, it is important to recheck the capillary blood glucose level within 15 minutes. If the patients have complete resolution of symptoms and if the capillary blood glucose level is more than 70, then we just need to do ongoing monitoring of the patient for any subsequent episodes of hypoglycemia. At the same time, ensure that the patient takes the meal and also try to evaluate the etiology of that episode of hypoglycemia and ensure that the future such episodes do not occur by educating the patient on how to recognize symptoms at the earliest phases. Irrespective of whether the patient has had an oral or an IV treatment of hypoglycemia, almost near complete resolution of symptoms occurs very quickly as soon as the treatment is initiated. With IV treatment, within 5 to 10 minutes, there is near complete resolution of symptoms and the patient becomes asymptomatic. If there is persistent symptoms in spite of repeated doses of dextrose at 30 minutes, it is important to consider other causes of neurological deterioration and refer the patient for further assessment and evaluation at this point. 50% dextrose is a highly irritant solution, and it's important that we give it via a wide bore cannula or with a proximal vein. In the initial setting of hypoglycemia, it's important that we do not initiate treatment with 10% or 5% dextrose because there is a risk of fluid overload at that stage. Once the euglycemia has been achieved, ongoing maintenance therapy can be maintained with 5 to 10% dextrose if a subsequent episode of hypoglycemia is expected. However, it's important not to be aggressive and swing the pendulum to the hyperglycemic side. Take a pragmatic approach and try to maintain blood sugar levels at less than 200 at all times. It's important to prevent subsequent episodes of hypoglycemia by giving appropriate orders of insulin and anti-diabetic agents in the perioperative period. Regular monitoring of capillary blood glucose at the bedside every 4 hours. Educating patient about symptom recognition and early and appropriate treatment initiation. Avoiding excessive NPO status, which is unnecessary in the post-operative period, and having diabetic patients take their regular meal at the earliest possible point, and also having systems in place in order to avoid medication errors in the hospital is important to avoid hypoglycemic events. Thank you.
Thank you, Dr. Vinita. That was a lovely physiological progression of symptoms and management. Very well said. And it's very important to remember they come under the vulnerable group, the vulnerable patient policy. So tagging them and identification of diabetics as a vulnerable group in an organization is very, very important, especially in an ophthalmic setup. Let me welcome our next speaker. And the topic is hypertensive crisis and acute pulmonary edema management. And the speaker is Dr. Iris M.C. Rajiva. She's a vitreoretinal anesthesiologist with an experience of almost 25 years, and she is now with the Retina Institute of Karnataka. Over to Madam.
Good evening, friends and colleagues. I bring you greetings from Retina Institute of Karnataka. Today I'm speaking on acute hypertension crisis and ophthalmic surgery. The incidence of hypertension is most prevalent in more than 50% of ophthalmic surgery patients. They have long-standing hypertension associated with coronary artery disease, stroke, dementia, renal disease, vascular disease, hypertensive retinopathy, and neuropathy. They are on concurrent antithrombotics too. In hypertension, there is left ventricular hypertrophy, and these are the various end organ damage that's produced by hypertension. Hypertension more than 180 by 120 is considered as hypertensive crisis. There are two types of crisis. One is urgency and the other one is emergency. In the first one, there is markedly elevated blood pressure without severe symptoms or progressive target organ damage. BP can be reduced with oral agents within hours. In hypertensive emergencies, markedly elevated blood pressure occurs with acute or progressive target organ damage. BP should be reduced immediately with parenteral agents. The predisposing factors are cardiovascular hypertension, diabetes, and smoking, which leads to acute blood pressure and acute volume, causing increase in the left ventricular end-diastolic pressure and pulmonary edema. In hypertensive crisis, this is the pathophysiology, where the increase in blood pressure causes a failure of autoregulation. This causes an increase in resistance, causing increase in vasoconstriction. This leads to a prothrombotic state, and there is endothelial injury. There is activation of the renin-angiotensin-aldosterone system. The endothelial injury causes ischemia and target organ damage. This progresses to congestive heart failure. Congestive heart failure causes most common signs and symptoms of fatigue, edema, shortness of breath, and chest pain. This is the alveolar capillary where oxygen and carbon dioxide exchange takes place. Here there is buildup of fluid causing pulmonary edema. In acute pulmonary edema, the patient should be made to sit up and the vitals should be monitored. The systolic blood pressure is more than 100. Sublingual glycerol trinitrate should be given every 5 minutes. If there is evidence of fluid overload, give 40 mg of furosemide. If the oxygen saturation is less than 92%, give oxygen, and if it doesn't improve, provide CPAP or BiPAP. We have to find out whether the patient has got acute symptoms and signs of acute end organ damage. If the patient is critically ill, consider giving sodium nitroprusside. If there is angina, give a beta blocker in addition. For pulmonary edema and neurologic emergencies, nitroglycerin and nicardipine can be considered. If the patient is being actively treated for congestive heart failure, also you can consider sodium nitroprusside if the BP is high. If the current BP is less than not high, immediate treatment is not necessary. If it is high, you can consider intravenous labetalol, metoprolol, or intravenous hydralazine. These are drugs commonly given for hypertension. In hypertensive acute pulmonary edema, the patient can present with tachycardia and a blood pressure of more than 180 with bronchi and crepitations in the lungs. Oxygen supplementation improves the work of breathing, increases the intrathoracic pressure with reduction in preload and afterload. and nitroglycerin is given to reduce the afterload and at high doses, which causes vasodilatation more than venodilatation. ACE inhibitors are given to provide continuous afterload reduction. Pressure overload, ischemia, hypertrophy, and myocardial infarction, there is abnormal relaxation and increased stiffness. This can cause abnormal early filling, leading to diastolic abnormalities, or elevated LV filling pressures, causing reduced exercise tolerance and diastolic dysfunction. It also can cause elevated left atrial pressure and left atrial size, leading to atrial fibrillation, decreased cardiac output, and reduced exercise tolerance, causing congestive heart failure and diastolic heart failure. Now, how do we prevent all these? In our ophthalmology practice, a lot of sympathomimetics are used, like ephedrine and phenylephrine, which causes tachycardia and dysarrhythmias. The methods to reduce systemic side effects of topical drugs is to use the double dot technique, where it is don't open eyes technique and digital occlusion of the tear duct. This picture shows how the lacrimal sac, then the punctum is occluded. Here, this is what we do in our institution. When the dilatation is not sufficient, after giving the block, the punctal occlusion is done. Safe approach during ophthalmic regional blocks is to premedicate and sedate the patient with midazolam, melatonin, or alprazolam. In a hypertensive patient, include atenolol and, if necessary, a calcium channel blocker. If the patient is already on a beta blocker, the premedication is tailored accordingly. Tune your ears with the ECG beeps on the monitor. This is how we are putting sublingual nicardia in the operation theatre if required. Addressing the patient's pre-op stress and improves the final post-op outcome. Daycare new patients experience significantly higher levels of pre-op stress and anxiety than do inpatients. So recommendations are the pre-op assessment of stress, anxiety profile by providing appropriate counseling and preconditioning. So the patient should be given reassurance and patient education and patient counseling. This will all go a long way to busting the anxiety. We have come a long way, yet there is a scope to refine further. Thank you. Should I say it again?
Thank you very much, Dr. Iris. That was a very well pictorial and very well represented presentation. Our next topic is adverse drug reactions by none other than Dr. Jayachandran himself. I have already given an introduction to him. We can start with his presentation.
Good afternoon, everybody. Myself is Anesthetist Dr. Jayachandran VV. At the outset, I would like to thank the Karnataka Ophthalmological Society for having given me this opportunity to talk on a most important topic, that is adverse drug reaction. WHO defines adverse drug reaction as a response to a drug that is noxious, unintended, and occurs at doses normally used for prophylaxis, diagnosis, or therapy of disease or for modification of physiological functions. There are totally 5 types of adverse drug reactions that are reported to occur. Type A is augmented, that is dose dependent. Say for example, if a patient is given too much of antihypertension, it can result in hypotension. Type B is bizarre type of reaction, that is dose independent, and it can be due to an allergic or idiosyncratic reaction. Type C is chronic, when the patient is taking a drugs for a long period. For example, analgesic resulting in interstitial nephritis. Type D is delayed, thalidomide resulting in teratogenesis effect. And type E is withdrawal and rebound. Say for example, insomnia and anxiety disturbances following benzodiazepines withdrawal. Now today in this presentation, I will be sharing mainly the allergic and idiosyncratic type of reaction, and at the last I will be talking about type A reaction also. Allergic reaction in an ophthalmic setup can occur due to intravenous fundus fluorescent angiography, where the patient can develop nausea, vomiting, sneezing, itching, transient palpitation, chest tightness, dizziness, and cold sweat also. And allergic reactions in the OPD can occur due to installation of eye drops. The most important thing is allergic reactions to local anesthetics occurring in the perioperative area. Literature reviews totally shows about 4 cases of lidocaine hypersensitivity in ophthalmology. The first one is due to subconjunctival injection. The other one is due to peribulbar local anesthesia, where a 70-year-old woman complained of a sight-threatening acute orbital swelling, and potentially blinding adverse drug reaction to peribulbar lignocaine anesthesia have been reported, where in this case the patient developed a total optic atrophy. Also, an immediate reaction to lidocaine with periorbital edema during upper blepharoplasty has been reported. Half late, allergic reactions to local anesthetic adjuvants, namely hyaluronidase, have been reported in a large numbers. And this is one of our presentation where we had a total of 5 cases, and all these patients presented with periocular edema, proptosis, and restriction of ocular movements. And one patient had a compartmental like syndrome also, where we did an emergency canthotomy, and rest of the patients were treated with IV steroids and anti-allergic medications. CT scan demonstrated mild proptosis of the left eye, and also there was a mild to moderate thickening of the left extraocular muscles. On literature review, nearly about 40 publications are there, where there have been hypersensitivity reactions to hyaluronidase have been reported following retrobulbar, peribulbar, and subtenon's block. The incidence is quoted to be somewhere around 0.05 to 0.69%. Here, this is a total review of allergic reactions to hyaluronidase, where we can see that localized signs and symptoms like proptosis, erythema, and extraocular muscle dysfunction has been reported, and systemically patients can develop angioedema, itching, tachycardia, dyspnea, anaphylactic shock also. The time of onset of reaction can be variable. It can be immediate, it can be early, intermediate, or sometimes it can be occurring within weeks also, that is called as late. Now, many of these patients had undergone an earlier surgical procedure that included hyaluronidase use, which suggests that these reactions might be the result of sensitization to the animal-derived product. Mechanism of reaction, namely 2 types they say. One is due to type 1 immediate hypersensitivity reaction. This is IgE mediated. It is mainly involves mast cells and basophils. Reaction is said to occur within 15 to 30 minutes from the time of exposure. Type 4 is delayed T cell mediated, where there occurs release of lymphokines and macrophage activation. Here we can see one of our patients developed a contralateral periorbital edema with mild puffiness of the face and earlobe swelling immediately following surgery. And this was a picture taken on the first post-operative day and third post-operative day. And the same patient, you can appreciate here the intradermal skin test for Hylase being positive here. You can appreciate the redness and induration here. Differential diagnosis includes retrobulbar hemorrhage and orbital cellulitis. Now, how to differentiate these? Orbital swelling, if it occurs immediately, then it is mostly due to a retrobulbar hemorrhage. CT scan, of course, can help you to differentiate between these 2 conditions. In case of orbital cellulitis, associated pansinusitis can be an incidental finding, or there can be any active sinus infection or purulent septic foci. Associated fever, pain, erythema can be there, and altered blood count, raised ESR and CRP can be associated features if it is an orbital cellulitis. Now, how to diagnose type 1? Mainly by intradermal or skin prick allergic test positive for hyaluronidase, whereas it is negative for all the other perioperative medications. Thus, In this picture, we can appreciate that it is negative for lignocaine, bupivacaine, and also a patch test being performed for sitavalon is also negative, whereas we can see here for hyalase and positive reaction occurring. Also, there are some serum IgE antibodies highly specific to hyaluronidase that can be detected. Type 4 means lymphocyte transformation test can be performed, and CT scan, as I was mentioning, also helps in the diagnosis. Now, once the diagnosis has been established, coming to the treatment part, it involves mainly IV antihistamines and steroids. In the presence of any compartmental syndrome, lateral canthotomy can be performed. Visual acuity, pupillary reaction, and extraocular movement should be monitored throughout. If it is an anaphylaxis like signs and symptoms, then it has to be treated on emergency basis. Epinephrine will be the drug of choice. 0.3 to 0.5 milligram intramuscularly is given, preferably in the mid-outer thigh, and it can be repeated every 5 to 15 minutes. Airway should be maintained, and place the patient in recumbent position. Give oxygen 8 to 10 liters per minute. Normal saline rapid bolus can be given if there is an associated hypotension. For bronchospasm, nebulization can be done with beta blockers. Then also antihistamines, diphenhydramine 25 to 50 milligram IV should be given. Steroids. Then monitoring includes non-invasive hemodynamic monitoring and pulse oximetry monitoring should be done. Urine output also should be monitored. Of late, at our institution, we are now included this preoperative allergic skin test, where half an hour before surgery, we perform this intradermal skin test to all patients who are allergic to food, insect bite allergy, allergic to any medicines, allergic rhinitis, allergic skin disorders, where we give 0.2 to 0.3 ml of 2% lignocaine with 12.5 international units of hyaluronidase in one forearm. If the response is negative, we perform the surgery. Suppose if there is a positive response in the opposite forearm, we again perform the intradermal skin test separately for Xylocard, hyalase, and ropivacaine. And if there is any positive, then accordingly we choose the local anesthetics and perform the surgery. Now, this is a typical example for a type A reaction that is augmented, where there is a cases of postoperative periorbital swelling owing to hyaluronidase used at a larger dose. And here they have reported a total of 7 patients. In all these cases, we can appreciate here a dose of hyaluronidase used was somewhere around 50 to 250 international units per ml. And all these patients, they showed negative allergic test. Thus, they are diagnosed as a type A reaction. Also in this eye journal, an orbital swelling following peribulbar and subtenon anesthesia owing to hyaluronidase excess dose have been reported. Now, the British National Formulary recommends a safe hyaluronidase dose as 15 international units per ml for ophthalmic blocks. At our institution also, we use hyaluronidase at around this 15 international units per ml. Now, coming to the prevention of acute adverse drug reaction, always it has to be reported as an incident. Thorough evaluation should be done by multidisciplinary team members. Cause for the reaction should be established. Regular educational program must be carried out. Remember, publishing it in medical literature will increase the awareness. That is most important. To conclude, adverse drug reaction in an ophthalmic setup can occur anywhere. It can be at OPD, it can be at OT, it can occur due to eye drops, FFA. Remember, most importantly, it is due to the local anesthetics and adjuvants. Careful preoperative history taking is very important. Look out for always for allergic signs and symptoms. Be prepared. IV line should always be established. Emergency crash cart and airway equipment should always be kept ready. Once if you have diagnosed as adverse drug reaction, report it and publish in medical literature so that it can increase the awareness among the healthcare professionals. Last but not the least, to know about the more about the systemic complications and its management, I would like you all to go through this book, that is Principles and Practice of Ophthalmic Anesthesia, that have been brought out by us in the year 2017. And happy to share that Dr. Shuman Sri, who is also a moderator for this session, is also one of the authors in this book. Thank you all.
Thank you very much, Dr. Jayachandran. It was definitely a very relevant topic. We are seeing this every other day, high-less reactions. And now we know how to manage this, and especially how importance of reporting these incidents. And very well researched presentation, I must say. So thank you very much. We're deeply honored to have you as one of our speakers. Let us move on to the next topic, perioperative bronchospasm. We are in Bangalore, the allergic city of India. So we see it very often in our clinical practice. And we have a very senior consultant, Dr. Parimala B, very dynamic anesthetist too. She is with NU Hospitals Trust. She was also one of our consultants at Netradama. And she has 15 years of experience. She has more than 3-4 publications. And she's a gold medalist in her anesthesia PG program. Over to Dr. Parimala.
Good evening, everyone. Dr. Parimala here from NU Hospitals, Bangalore. I would like to thank Dr. Ilan Kumar and QoS for providing this opportunity to be here for this presentation. My topic for discussion is perioperative bronchospasm. It's a very vast topic to be covered in 10 minutes. So I'll keep my discussion relevant from ophthalmic point of view. Starting with basics. Perioperative bronchospasm is narrowing of airways resulting in decreased lung compliance in the preoperative, intraoperative, or postoperative period. In preoperative period, bronchospasm may present as cough and breathlessness. In the intraoperative period under general anesthesia, it presents as prolonged expiration with increased peak airway pressures, which is heard as an alarm on the anesthesia monitor. The complications of perioperative bronchospasm are hypoxia, hypercapnia, hypotension, leading on to increased morbidity and mortality. The complications are significant and serious under general anesthesia and may be relatively less concern under regional anesthesia, nerve blocks, and local anesthesia. And what is the most common type of anesthesia used for ophthalmic surgery? It is nerve blocks or local anesthesia, and now we have even moved on to topical anesthesia. IV sedation and GA are used for some long procedures or uncooperative patients or in pediatric patients. So when we are doing all procedures under blocks and local anesthesia, should we be really concerned about bronchospasm in ophthalmic surgery? Let's discuss this. What are the unique requirements of ophthalmic anesthesia and surgery? Maintenance of intraocular pressure is the cornerstone of ophthalmic anesthesia. Along with that, immobile patient, ability of the patient to lie supine comfortably, no cough or bucking are essential requirements for ophthalmic surgery. Control of intraocular pressure before, during, and after the procedure is important because increase in intraocular pressure results in optic nerve ischemia and bleeding complications. So the reason why we are concerned about bronchospasm in ophthalmic surgery is that it causes coughing, breathlessness, raised central venous pressure, hypoxia, and hypercapnia, all of which increase intraocular pressure. How? A brief explanation. Coughing increases intraocular pressure by 40 to 60 millimeters of mercury and is also associated with significant patient and head movements, which makes surgery challenging. Also, when patients are breathless, they can't lie supine and they start moving or become apprehensive, especially when the head is draped for the surgery. Persistent bronchospasm results in right heart failure, thereby increasing central venous pressure, and hence IOP increases. Hypoxia causes dilatation of the choroidal blood vessels and increases choroidal circulation, resulting in increased IOP. Bronchospasm is associated with prolonged or incomplete expiration, resulting in carbon dioxide accumulation, causing hypercapnia, respiratory acidosis, result increased IOP. So all the symptoms and complications of bronchospasm will increase intraocular pressure and hence affect the outcome of the ophthalmic surgery. Because of this reason, a proper preoperative evaluation with focused perioperative intervention becomes very important to prevent the effect of bronchospasm in the intraoperative and postoperative. We'll now discuss management of bronchospasm. This will be discussed under two headings. One is preoperative optimization and the other is intraoperative bronchospasm management per se when the complication occurs. Under pre-op optimization, optimization of lung function and optimization of therapy, both are of importance. So preoperative optimization of lung function, this involves a discussion on smoking. Smokers need to quit smoking in the preoperative period because smoking increases bronchial secretions, decreases mucociliary clearance, and also has effect on the immune functions. Ideally, smoking has to be stopped 6 weeks prior to surgery. However, if that much time is not available, whatever time duration is available, stopping smoking has been proven to be beneficial. Incentive spirometry increases the lung capacities, thereby helps in better oxygenation and removal of carbon dioxide. Physiotherapy is very useful in bronchiectasis cases where a lot of secretions needs to be removed, and also physiotherapy helps in opening up the collapsed alveoli, so helps in better oxygenation. A course of appropriate antibiotics helps in preventing respiratory infections in the intraoperative and postoperative period. Coming to optimization of therapy, commonly used drugs to treat bronchospasm are inhaled beta-2 agonists and steroids. All patients of bronchial asthma are generally on one or other type of inhalers. The common inhalers used are inhaled beta-2 agonist. This is the mainstay of treatment for bronchospasm. Commonly used drugs are long-acting beta agonist like salmeterol or short-acting beta agonist salbutamol. Inhaled steroids are also used as first line of drug for bronchospasm because of its anti-inflammatory action. They may be used inhaled form like budesonide and fluticasone, or even systemic steroids like prednisolone, methylprednisolone are used for severe cases of bronchospasm. The other supplementary drugs used are montelukast, has been proven to be very beneficial in preventing episodes of bronchospasm. Ipratropium helps to reduce secretions. Mast cell stabilizers are helpful in exercise-induced asthma. And methylxanthines continue to be used in spite of significant systemic side effects. Now let us discuss a practical stepwise approach when a patient with known history of bronchial asthma comes for a surgery or for pre-anesthesia checkup. We have categorized patients into 4 categories depending on their symptoms and the treatment they are on. And then look at what additional treatment is required. First category of patients, they have no symptoms and are not on any regular treatment. So they may have some episodes of wheezing during seasons. These patients can be taken up for surgery without any empirical treatment. The next category is patients who are free from symptoms for last 3 months and they are on regular inhaled beta-2 agonist and steroids. In these patients, continue their inhaled therapy and add a nebulization with beta-2 agonist and steroids before shifting to OT. The next category is the patients who have recent increase in symptoms and on regular inhaled long-acting beta-2 agonist and steroids. So in these patients, you have to continue their inhaled therapy. Along with that, add inhaled short-acting beta agonist and also a short course of oral steroids 3 to 5 days before surgery. The last category of patients are those who have persistent daily severe symptoms in spite of being on regular inhaled long-acting beta-2 agonist, steroids, and systemic steroids also. These patients need surgery to be rescheduled and continue all the treatment plus bridge with the frequent nebulized doses of short-acting beta-2 agonist and high dose of steroids may be required, especially 3 to 5 days of IV steroids is used in these patients before surgery. Now, management of intraoperative bronchospasm when it happens on table. Under regional anesthesia or nerve blocks, like in ophthalmic setup, we put patient on oxygen mask, stop surgery for a while if possible, and administer IV steroids and methylxanthines, nebulizations with beta-2 agonist and steroids, inhalers, which the patient have been using in the preoperative period, is very helpful. If bronchospasm does not settle with all above measures, a small dose of IV adrenaline is very useful. However, awake patients, very difficult to tolerate the side effects like tachycardia. And when bronchospasm happens under general anesthesia, it's a life-threatening complication because ventilation is compromised significantly, thereby affecting oxygenation. So hypoxia sets in. Stop surgery, ventilate the patient with 100% oxygen, and all our volatile agents, anesthetic agents or bronchodilators. So deepen anesthesia with volatile agents and use other bronchodilators like ketamine, which are immediately available on table. Inhaled beta-2 agonist is attached to the inspiratory limb of the ventilatory circuit so that the beta-2 agonist reach the lungs along with the ventilation and help in bronchodilation. IV steroids is used. Again, in resistant cases, the drug of choice will be IV adrenaline, 1 to 2 micrograms per kg, which shows a significant improvement immediately. To summarize, bronchospasm rarely causes life-threatening complications like hypoxia, hypotension under nerve blocks and local anesthesia, but still it is of major concern because it causes cough, breathless, making patient uncooperative for surgery under blocks and local anesthesia, and also all this increase IOP, thereby affecting the surgical outcome. So preoperative optimization of lung function is the key for successful outcome of the surgery. Thank you.
Thank you very much, Dr. Parimala. That was a lucid and a very clear management line for bronchospasm. And in fact, we have a nebulizer or on crash cart itself. It's so important. And I guess being forewarned is being forearmed. So very important to note it down in the pre-anesthetic evaluation. That were the history of bronchospasm and being ready, prepared always. That was wonderful, Parimala. Thank you very much. We go on to our next topic, acute coronary syndromes, especially acute myocardial infarction. It's my privilege to welcome Dr. P.M. Chandrasekhara, who is a doyen in the field of anesthesiology with almost 50 years, golden anniversary of anesthesia. We are very, very fortunate to have him amidst us. And he is a consultant, a cardiac anesthetist at Retina Institute of Karnataka. Over to you, sir.
Good morning. I am Dr. P.M. Chandrasekhar. I will be talking about cardiac morbidity in a patient with PMI. To start with, I will be bringing a greeting from Retina Institute of Karnataka. And my topic will be perioperative cardiac morbidity. And the scope is I will be presenting a case of PMI and how to manage the patient and also practice guidance. Here is a 68 years old man scheduled to undergo MIVS. He has got IHD and hypertension, and a previous history of ICU admission, and is stabilized with a 2-vessel PTCA. He is on anti-hypertensive and clopolate, and occasionally he takes a nitroglycerin sublingually. And how you would fare during the surgery is, we know that following a non-cardiac procedure in a cardiac patient undergoing minor surgery, we will have perioperative cardiovascular complications, and we have to draw the evidence-based guidelines recommended by American College of Cardiology and Heart Association. Ischemic heart disease and coronary artery disease has attained an endemic stage called lifestyle disease or endothelial disease or atherosclerosis, associated with longevity of life, diabetes, smoking, and obesity. Atherosclerosis has a genetic disposition also. It is the abrasion of microvascular endothelium or intima. And we can do the gene sequence and also identify the risk factors. Review under consideration. Thus, one should not concentrate on heart alone. Retinal vessels illustrate the vascular endothelial changes. Like diabetes, ischemic heart disease is a part of end-organ disease. Multi-organ system including brain, retina, carotid, retinal vessel, and peripheral vascular system should be evaluated. Atherosclerosis is also with other metabolic conditions like diabetes, obesity, and hyperlipidemia. These are the causes for this one. End organ disease of the vascular system. And heart attack occurs whenever there is a blockage of one of the coronary vessels, and it will cause muscle damage or ischemia ending in infarction. It can be due to the plaque rupture of the thrombus or vasospasm or clot formation inside the. And now we have got a genome technology where we can identify the gene that is involved and also tell us when we are heading for ischemic heart disease about 10 years earlier. In India, the 3 million die of cardiovascular disease every year. Heart disease is a primary killer in the country. 60 to 70% of the population is prone for cardiovascular disease. In India, the heart attack occurs amongst the youngsters with more severity and higher frequency. And mortality due to cardiovascular endothelial disease is twofold over the other diseases. Surgical patients above 65 is increasing by 100%. And also is an age-related disease. And also with under present COVID situation, lifestyle disease is becoming more because of inactive lifestyle, contributes to higher blood cholesterol level and IHD and obesity. What is perioperative myocardial infarction or perioperative cardiac morbidity is, by definition, acute coronary syndrome following disruption of vulnerable plaque. Patient experiences ischemic comfort resulting from reduction of flow through the affected epicardial coronary artery. The pathology of the is plaque rupture in a non-critical stenosis causing the total obstruction and resulting in myocardial infarction. And maybe it is as a result of uncontrolled hypertension during surgery or severe tachyarrhythmia, severe anxiety, severe pain, and some of the drugs that we put into the eye, and also there will be a hypercoagulable state during surgery. And how the ischemia, if it is not results in necrosis of the tissue. These are the stages and also how they present to us during different stages, and how angina and acute coronary syndrome will occur when there is a total blockage. And here is a picture where the blood flow is totally occluded by the ruptured plaque. And also they may end up in congestive heart failure if it is not treated. And pathophysiology is because of the narrowing of the vascular endothelium as a result in hypertension and coronary artery disease. Vascular endothelium is the body's largest organ, the endocrine organ, 1 cell thick, and it has got 1 to 2 trillion endothelial cells. Surface area is 4 square centimeter, 6 tennis court, and weighs about 1.5 kg. And its function is control of the vascular wall function in response to the circulating chemicals and also pressure. And this is a complex picture showing how vascular wall gets damaged and what are the chemical reaction that takes place, resulting in vasoconstriction, leukocyte addition, platelet aggregation, and cell proliferation. We can have a risk stratification before subjecting a patient for surgery, and most commonly done is the exercise testing, provides information about the cardiac status, guides about the therapeutic strategy that you have to adopt before subjecting them for surgery, and also it gives a target heart rate and BP control during surgery and before surgery. This stratification also ascertains the atherosclerotic cardiovascular disease and what are the things that we can control before taking the case. Multivariable disease indicates the associated condition that we can evaluate during the surgery. And during physical examination, we look for the blood pressure at different positions, look for jugular vein distension, auscultation, and lung also for pulmonary complications, presence of pacemaker ICD, and other conditions. Functional capacity is also we can assess before the surgery, what are the routine activities that he can attend, or he can climb a stair, or he can conduct strenuous exercise. Usually if we ask the patient can do daily run over 60 minutes, no more functional capacity tests are required. Echo assessment is very, very important non-invasive study. It gives the overall cardiac function, especially ejection fraction. If it is below 40, postoperative morbidity is assured. And ECG provides the basal record and it gives a clinical predictor of increasing perioperative risk and also tell us about the recovery after infarction. How the ST elevation occurs when a thrombus formation occurs and blocks this one. This gives the different scores about the ischemia, necrosis, and infarction. The ECG also gives us the quality, quantity, and duration and the age of the infarction. And we can also interpret the ischemia in different ways. And also we can localize which coronary arteries blocked and what is the prognosis. During surgery, we'll be monitoring the ST segment analysis and it will give us the maximum changes that is taking place. And regarding the antiplatelet agents and whether to discontinue or continue during surgery, better to have an idea and discuss with the cardiologist or recommending the case, but usually there is no need to discontinue. What are the comorbid conditions that one could control is, especially in renal patients, they'll have accelerated hypertension and it is better to control the blood pressure as far as possible and take the surgery a day after following dialysis. Diabetes, we know that hyperglycemia and patients who are on insulin therapy are high risk, and it's also endocrine disease. Perioperative therapy that we can give is start with the beta blocker. It's the rate control therapy, and it will reduce the oxygen demand by the myocardium, and it is recommendation is to continue the blockers. And calcium channel blockers, diltiazem is a vasodilator, again provides some better collateral blood pressure, blood supply to the myocardial. Statins are recommended because it will reduce the cholesterol level and will improve the platelet integrity. And these patients usually present with a preoperative surgery or balloon, or and they may also give a history of shortness of breath, and sometimes they may present with other complications like arrhythmias and tamponade. And overall management, if occurs, is recommended here, and we can send some sample for troponin estimation or to assess and refer the case to cardiologist. And IHT patient present for ophthalmic surgery poses a challenge of anxiety, calls for pre-operative workup, meticulous optimization, preconditioning, and perioperative monitor anesthesia care, and post-operative follow. Successfully managed patient will be able to see better, and that's smile. Thank you.
Thank you very much, sir. That was a very crystallized presentation of a very tough topic, I must say, but very well said. I guess we have just covered all the pre-arrest scenarios so far. And now if an arrest has taken place, a code blue situation in the hospital, what do we do? So we go on to the last topic of this session, code blue, the BCLS and the CCLS Indian Resuscitation Council guidelines by me.
Good evening to one and all. At the outset, I would like to thank Dr. Ilan Kumaran for inviting me for this lecture. Code Blue, the BCLS and CCLS Indian Resuscitation Council guidelines. The various scenarios in an ophthalmic practice that may need cardiopulmonary resuscitation are a vasovagal attack or severe bradycardia leading to cardiac arrest, anaphylactic reactions during invasive procedures like FFA, a cardiopulmonary arrest during local or general anesthesia, acute coronary syndromes, including an acute MI, severe hypoglycemia, and even life-threatening cardiac arrhythmias during high-risk procedures like intravenous methylprednisolone. CPCR or cardiopulmonary cerebral resuscitation goals are to support and restore effective circulation, oxygenation, and ventilation with a return of intact neurological function. An intermediate goal is ROSC or return of spontaneous circulation. How do we diagnose an arrest? Patient is unresponsive, apneic or no normal breathing, and there's an absence of a palpable pulse in a large artery, usually the carotid artery. If it is a witnessed cardiac arrest on a patient with a cardiac monitor, the cardiac arrest rhythms could be ventricular fibrillation or VF, pulseless VTach or ventricular tachycardia, asystole or flat line, or pulseless electrical activity. So what do we do? C, A, B. C for chest compressions, A for the airway management, and B for effective breaths. The IRC guidelines of 2017 are based on the experience of the rescuer, the place of resuscitation, and the availability of facilities. We have three algorithms. COLS or compression only life support for outside the hospital by untrained laypersons, coded in yellow color. Basic cardiopulmonary life support or BCLS guidelines for outside the hospital by trained personnel in green color. Comprehensive cardiopulmonary life support or CCLS inside the hospital by trained personnel, coded in blue. Let us go to the COLS guidelines. The callings are early recognition and activation, early chest compression, and early transfer. This is how the algorithm looks. Basically, we ensure safe place. check for response. If patient is non-responsive, start chest compressions, 30 chest compression, 5 cycles, and again check for response till higher care is available. Now for trained personnel outside the hospital, the callings being early recognition and activation, early high quality CPR, early defibrillation, and early transfer. This is how the algorithm looks. Let's look at it in the upper half as it is split. First of all, ensure safe place. Hello, are you all right? Checking for response, tap on the shoulder. If they're responsive, observe the victim in a recovery position and shift to the nearest medical facility. If they're non-responsive, shout for help or code blue. Call 108 and ask for the crash cart and the defibrillator. Check the breathing while palpating the carotid pulse within 5 to 10 seconds. 3 options are possible. 1, there's a normal breathing with a definitive carotid pulse. Put them in a recovery position, reassess every 2 minutes, and shift to the nearest medical facility. Or you could have an abnormal or no breathing situation with a definitive carotid pulse. That means we have to provide rescue breaths. It is a respiratory arrest. We provide 1 breath every 5 seconds, reassess every 2 minutes. The third possibility is an abnormal or no breathing without a definitive carotid pulse. This is a cardiopulmonary arrest. You start cycles of 30 chest compressions and 2 breaths. 5 cycles, 30:2, after which we check the carotid pulse for not more than 5 to 10 seconds. And we go back to the cycle. Now, this is a pictorial depiction of how we go about BCLS. We check for response. Then if the patient is responsive, put it in the recovery position, left lateral position in this way. Now, if they are non-responsive, we activate code blue and we check for breathing while palpating the carotid pulse this way. Now, if chest compression is required, we locate the xiphisternum, place the heel of one hand, 2 fingers above it, put the heel of one hand over the heel of the other, interlock the fingers, and lock your elbows. Deliver effective chest compressions at the rate of 120 per minute to a depth of 5 to 6 centimeters, allowing for complete chest recoil. Next, we look at the airway, the head tilt and the chin lift technique. This is to prevent the tongue from falling back and obstructing the airway. Later on, if we have certain airways like the oropharyngeal airway, we could use it, or the nasopharyngeal airway. We can measure it from the angle of the mouth to the angle of the jaw, and for nasopharyngeal, from the tip of the nose to the lobe of the ear. Next, we go on to breathing. That is, either it is mouth to mouth, or through a pocket CPR, or through an ambu bag. We use the C and E technique with our hands, and we do 30:2. If it's difficult to maintain the airway, we can also use an advanced airway like a laryngeal mask airway. This is the insertion technique. So the key messages being, we need to deliver each breath over 1 second and give 1 second pause. Start the chest compression immediately after the second breath. Importantly, switch your roles of chest compressions and breathing after the 5th cycle, that is 2 minutes. Now we look at the latter half of the algorithm. Once the defibrillator has arrived, we attach it, then we have to analyze it. While attaching the pads, don't stop the chest compressions. But while analyzing the rhythm, don't touch the patient. If it is a shockable rhythm, we press the shock button. We can start with 120 joules, escalate it to 200 joules. If it is an automatic external defibrillator, it is auto-selected. If it is not shockable, we resume high quality CPR. Continue the cycles till the victim becomes responsive. Either he moves, coughs, or vocalizes, or pulse and breathing returns. Then the victim is shifted to the medical facility. So various ECG rhythms in a cardiac arrest, which are shockable, are ventricular fibrillation, which looks like this, and pulseless ventricular tachycardia. The non-shockable rhythms are asystole and pulseless electrical activity. Once an AED arrives, we power on the AED. we attach the electrode pads to the victim's bare chest. We clear the victim. You are clear, I'm clear, all are clear. Then we analyze the rhythm, press the shock button, continue the CPR, starting with chest compressions. If you have a manual defibrillator, it could be biphasic or monophasic. We power it on, attach the chest lead, set the charge, biphasic 120 to 200, monophasic 360, children 2 to 4 joules per kg. Then we charge it, we place the sternal pad, the apical pad, I'm clear, you're clear, we're all clear, press the shock button and continue with CPR without interruption. Most importantly, the do's and don'ts are in adult CPR. We compress at 120 per minute, depth of 5 to 6 centimeters, allow full chest recoil, minimize pauses in chest compressions, and ventilate adequately. 2 breaths after 30 compressions, each breath delivered over 1 second, each causing adequate chest rise. Now we go on to comprehensive cardiopulmonary life support, or CCLS. This is inside the hospital. The callings being early recognition and management of pre-arrest conditions. Early recognition, activation of code blue, early high quality CPR, early defibrillation, and early comprehensive life support and post-resuscitation care. Well, the CCLS emphasizes the need to recognize patients at risk for cardiac arrest and their timely management before a cardiac arrest occurs. Basically, we need to have a high suspicion index for pre-arrest scenarios. The basic components include chest compressions for blood circulation, airway maintenance, lung ventilation, defibrillation to convert a pathological shockable rhythm to one capable of effective blood circulation. The CCLS emphasizes incorporation of airway management, drugs, identification of the cause of the arrest, and its corrections, while the chest compression and ventilation are going on. It also emphasizes the value of organized team approach and optimal post-resuscitation care. Now, this is how the CCLS algorithm looks. You will notice the first part and the middle part is the same as the BCLS algorithm. The only thing which changes is the lower 1/3 of the algorithm. So I have already completed the BCLS. Now we will go on to the simultaneously during the cycles of CPR, we need to ensure 3 things. One is venous access or intraosseous access if it's not possible, airway management considering definitive airway, drugs like administering 1 milligram of adrenaline intravenous, repeating every 3 to 5 minutes. Various anti-arrhythmics are also considered for refractory VF and pulseless VTAC, that is amiodarone 300 milligrams IV bolus, second dose of 150 milligrams, and identifying the reversible causes and treating them. The mnemonic is hit the target. And all the time, please remember, high quality CPR, 120 per minute, 1 breath every 6 seconds. Very important aspect of CCLS is intravenous route is a preferred choice. Give the drug bolus, administer 20 ml bolus of IV fluid, elevate the limb for 10 to 20 seconds after giving the drug. Intraosseous is alternate route. Endotracheal route is a rescue choice. We have to give 2 to 2.5 times the IV dose, dilute in 5 to 10 ml of normal saline, and the drugs are in a mnemonic called alone. A for atropine, L for lignocaine, O for oxygen, N for naloxone, and E for epinephrine. We need to dilute 1 milligram of adrenaline in 10 ml of normal saline and administered as a bolus, repeated every 3 to 5 minutes. Administer while ongoing chest compression. If after initial 2 to 3 of such 5 cycles of CPR, arrhythmias persists, we have to give anti-arrhythmic drugs like amiodarone, 300 followed by 150 mg, and other appropriate drugs to manage the rhythm and the blood pressure, like vasopressin, Zalocard, magnesium, dopamine drip, etc. So what are the reversible causes? Hit the target. H for hypoxia, I for increased hydrogen ions, that is acidosis, T for tension pneumothorax, T for toxins or poisons or toxicity or overdose, H for hypovolemia, E for electrolyte imbalances like hypo or hyperkalemia, T for cardiac tamponade, A for acute coronary syndromes, R for raised intracranial pressure like subarachnoid hemorrhage, G for glucose hypos or hypo or hyperglycemia, E for embolism like pulmonary or thrombosis, and finally temperature variation like hypothermia. These are the important contents of a crash cart, most important being your adrenaline and your atropine. And finally, if you've had a successful resuscitation, restoration of your cardiac rhythm, effective cardiac output through pulse and blood pressure, spontaneous respiration, pupils constricted and reactive, return of consciousness, and shifting the patient to the nearest ICU or CCU. This is how a code blue drill is conducted. There's a role play in the CPR team. We have team leader at the foot end, airway manager, ventilator at the head end, and on either side, we have the chest compressor, the monitor defibrillator, recorder on one side, and the venous access with medications on the other side. Now, how do we know when do we terminate a resuscitation? Once the reversible causes have been ruled out and corrected, based on clinical judgment, a decision can be taken to discontinue it. ETCO or capnography is a very good sign of perfusion, can be used for prognostication in intubated patients. With high quality CPR, an asystole for more than 20 minutes or ETCO to less than 10 millimeters of mercury can be considered as a sign to stop resuscitation. Well, in suspected COVID patients, you need to don PPE and you need to have a doffing area designated. In child CPR, if there are two rescuers, we can do 15:2, and chest compression techniques can be 2-finger or chest encirclage method, the rest being the same. Now, to summarize, we have COLS, BCLS, and CCLS core links. In NABH Eye Care Organization, NABH standards, we have COP3 or care of patients with 3 objective elements where we need to document policies, procedures, and how we go about CPR training program, and how do we document the post-event analysis in a recorded way. And this is how we do it in Netradama. We have a recorder sheet and post-event analysis. Thank you very much.
Thank you, madam. That was an exhaustive session. And for people who have not even seen, who have seen only drops as anesthesia, that was excellent. In fact, I would like to say the first time I had a vasovagal, I didn't know what to do for a minute or two. Though we were trained, this is what happened. Thanks for that excellent session from all the seniors, Dr. P.M. Chandrasekhar sir, Dr. Iris Rajiva madam, Dr. Vinita, Dr. Parimala, Dr. Jayachandran, and thanks a lot. You put up this program in an excellent way.
Thank you very much, Dr. Elan, and for giving us this opportunity. I hope this saves lives and makes your life much better in all the ophthalmic practices. Thank you once again.
Thank you. Thank you, everyone.